and we have Department of Nuclear Medicine. They are going to discuss PET-CT guided biopsies. And I hope they will address the issue that how is it better than CT guided biopsy? And we'll hear their experience from Dr. Gambhir.
Good morning. As you can see, the topic PET-CT guided metabolic biopsy. So those who are user of the PET imaging, they can get a lead or a pretty good impression, what it's going to be about. But as usually the crowd is mixed, and for those who are uninitiated with the nuclear imaging, so the keywords here are the PET-CT metabolic biopsy. So we call functional or metabolic because when we use a radioligand, it targets a tissue because of its change in the metabolism of the tissue or organ. So that's why we at times use functional or we use metabolic. So our ligand is targeting a tissue because of a specific function of those group of cells or tissue. So that's why PET-CT imaging is used in the diagnostics. Here's using the same lead. Now, once you have that tissue, as you can see on the right, on the top, normally we use the FDG. Everybody is aware of fluorodeoxyglucose. So change in the glucose metabolism, usually in tumor versus inflammation and other disease, malignant versus non-malignant. So that's the most common used radioligand in PET imaging, but we have many like gallium, PSMA for prostate and all those. So we can use any of these to elicit or highlight a tissue which has a particular kind of metabolism, which is likely to be a diseased pathology. So once we have that, then we can target. The rest is the mechanical arm, we call the robotic arm. So this basically based on that image cross section you can see at the bottom right of the screen. So once the image is there on the image on the screen, we can mark the path of entry of the needle and the target, including the depth of the target. And this arm, robotic arm, has many dimensional change of function. It can rotate in any direction. And we can see on the image which tissue we are avoiding, which we don't want the needle to go through. So we draw the path on the image and the arm comes and places itself on that axis very precisely. So once it is placed there, then a needle is inserted, as you can see in the image, and details will be discussed. So we can reach the tissue in one go. One puncture, one go, you can take multiple. So it is a precise and efficient way of taking biopsies. Though the PET-CT has a CT component, so here we are using more of the functional imaging component. Though CT is there to back up. So we will explain how it's little different or better than the CT guided. And this tool is relatively new. So this machine is FDA approved and it is made in India machine. And now it is being exported all over the world. So that's why it first came in our hand, AIMS, Chandigarh, and we are doing a lot of other centers and now it's going. So the most of the data is coming from India, the Indian centers, as compared to the other centers. Now American centers have started taking interest in this thing. So we've been working over clinical groups in pulmonary medicine and urology and building our experience about it. Is very precise. So we thought of, giving that experience and take feedback from the people, though it can be used for other areas to target in this way. So Dr. Aftab has been leading this team who is doing these biopsies. So I'll request Dr. Aftab to take over from here. Thank you.
Very good morning to all of you. Today, we are going to explore a critical topic in the field of medical diagnostic, and that topic is dilemma in the conventional biopsy and potential use of metabolic biopsy where these dilemmas are existing. So as you all know, conventional biopsies are the gold standard, but these biopsy are having its own challenges. These challenges are biopsy. This biopsy they can potentially have sampling error due to tumor heterogeneity, and also they have its own procedural complication. And the greatest thing is these conventional biopsies depends upon the anatomical imaging. So sometimes these anatomical changes may not fully explore or fully in full extent they show the disease process, these anatomical changes. But on the other hand, when we use metabolic biopsies, we use radiotracer functional imaging. So the disease process itself that can be shown in the functional biopsy, functional image. So this functional biopsy target only those lesions who are functionally active. Thus, they are increasing precision and accuracy, and these are changing the management of the patient. In addition, if we use this functional biopsy with the automated robotic arm, so it itself increases the precision more because it target the lesion, even the small lesion with more precision, and it mitigate the human error, thus increasing the potential of the biopsy and also changing the management. So in this scenario, at the start, I will show you two case example so that everyone will have a small idea what we are going to present in the simpler way. So just take an example. It is a 62-year-old male. He has history of cough and difficulty in breathing for 3 months. He underwent CT scan, which shows a large mass in the lower lobe of the right lung, which apparently homogeneous in the CT scan image. For this patient, CT guided biopsy was done, and this biopsy was inconclusive because this was a large mass. So patient has a high suspicion of malignancy. So it was ordered for the FDG PET CT. So for this patient, FDG PET CT was done, and you can see the FDG PET CT showing concentration only in the medial part of the lesion. Here, I would like to tell general audience, this PET CT was done by using FDG injection. FDG is a glucose analog. So when we inject this FDG into the patient, it distributes itself according to glucose metabolism of the body, and its concentration increases with the metabolism, glucose metabolism of that tissue. And this area, we see this area as a hot spot. We say this is hot spot. And we assume if we take biopsy from this area, it will give us better understanding of the nature of the lesion, and it may be more conclusive. So this time, this needle was placed in this area only. You can see the needle tip here. So this coaxial needle tip was inserted into the metabolic area of the lesion, and biopsy was taken from this lesion only. And this turns out to be adenocarcinoma of the lung. So here you can see the potential of FDG PET CT in the metabolic biopsy. Now comes to the second example. Here, it is a 58-year-old male who presented with the lower urinary tract symptom like frequency and urgency since 8 months. He has increase in serum PSA around 14.8 nanogram per ml. Reference range of PSA में PSA value is 0 to 4 nanogram per ml. This patient underwent MRI prostate that revealed prostatomegaly with a small lesion in the right peripheral zone posteriorly at 7 o'clock position. Pilot 5 means it has very high clinically significant cancer suspicion. You can see in the MRI there is a pilot 5 lesion at the right peripheral zone at 7 o'clock position. For this patient, transseptal ultrasound guided 12 core biopsy was taken, and this biopsy was, there was no evidence of malignancy. You can see how the prostatic biopsy pattern in the transseptal ultrasound guided, and there were 12 cores taken, and this was negative. So because there was high suspicion of malignancy, so this patient underwent PET CT. But this time, this PET CT was done by using 68 gallium PSMA injection. I would like to tell you what is 68 gallium PSMA tracer. This tracer, it is specifically target where are the prostate specific membrane antigen expression in the body. So assumption is where is the more malignant tissue. So the prostate cancer, if there is a tissue of prostate cancer in the body, PSMA expression will be high. So this kind of PSMA will go to that area only where there is high potential of malignancy. Here in this image, you can see there is a small focus of PSM expression in the right posterior peripheral zone of the prostate, and this corresponds to the MRI image. So the question is, can we target this tissue specifically? Here challenges are different. This lesion is less than 1 centimeter. Depth from the surface is around 12 to 13 centimeter. Transguided biopsy is negative, so you need a target biopsy. If you go by the percutaneous transgluteal approach, this is 12 centimeter, even the small degree of deviation at the surface, negative, when it is inside, it will have a greater deviation. So this time, we targeted this tissue by using robotic arm. Here, what we do, we feed these PETs CT images to the robot. We give him command, where is our target lesion, where is the entry point, what is my needle length. So according to that, this robot arm align itself so that it's like a helping hand he is giving to us. So without dimension, with precision, I can go confidently into the lesion in one go. So here, yes, we put the needle, we got hit in one go. And this lesion comes out to be adenocarcinoma Gleason score 4 plus 3. So now with these two examples, you must be having a mota idea what we are going to present here. So now I am going to one to explore what we are going to discuss here. Dr. Prajwal will tell you what are the basic of pathology, how metabolic biopsy is being done, and what are the advantages of robotic arm. Then Dr. Siddharth will come and he will tell us what are the our experience and what literature is saying about the metabolic biopsy. Dr. Prajwal, please.
Thank you, sir, for inviting me to the stage. Good morning, everyone. I will talk about the importance of hybrid imaging and its application in biopsy guidance. We will start off by seeing a case of a lung cancer patient who came for FDG PET CT for pre-treatment staging. In this image, we are unable to pinpoint any bony metastatic lesion, and the CT looks grossly normal. However, looking at the PET CT image, there is intense FDG uptake at multiple vertebral levels, indicating metastatic disease. This is a scan of a post-treatment multiple myeloma patient with extensive lateral lesion on CT, who came for evaluation for residual disease. So based on the CT findings alone, it is difficult to determine which of these lesions are still harboring active myeloma cells. However, on FDG PET CT, there is metabolically active bony lesions involving the C7, D12, and L1 vertebrae. This uptake distinguishes metabolically active myeloma sites from inactive lateral lesions. So in both these cases, we used FDG as the radiopharmaceutical. Now I'll tell a few words about FDG. So FDG is a radiolabeled glucose analog where the hydroxyl group at the C2 position is replaced by radioactive fluorine 18 isotope. 18F FDG is taken up by cells through GLUT transporters and phosphorylated to 18F-FDG 6-phosphate, which finally gets trapped inside cells. Tumor cells, due to their high glucose metabolism, trap more 18F-FDG in comparison to the normal cells. This accumulation of tumors allows this accumulation of tumor uh, of FDG allows it to be visualized on a PET CT image. The image on the right side shows the cascade of events in disease progression. Different imaging modalities capture these changes at different points. As we can see, the PET imaging detects disease at the level of metabolic changes at nanomolar to micromolar level. So, which this thing precedes metabolic changes that are visible on anatomical imaging. For example, bony metastasis on CT will not be visible until 30 to 50% of cortical destruction has occurred, although metabolic changes will be evident on PET at that time. This corresponds to the first case that we discussed. This is an image of a PET CT machine usually used for acquiring this. So apart from FTG, there are other various tracers as well, which target other processes and molecules. Like for example, carbon 11 acetate, which is a marker of lipid metabolism, and carbon 11 methionine, which is a marker of amino acid metabolism. This is just an image showing how a PET and a CT image look like. And when we fuse these two images together, we get the fused PET CT image. So now let us move on to our main topic, that is biopsy. As we all know, biopsy is the process of extraction of sample cells or tissues from the body. This helps us provide definite histopathological diagnosis, differentiating benign from malignant lesions, monitoring disease progression, and assessing treatment. It also helps us assess molecular markers for guiding personalized therapy. In most of the clinical scenarios, a conventional ultrasound or CT guided biopsy usually suffice. However, there are few lacunae in conventional biopsies. By conventional biopsies, I mean anatomical guided, which are ultrasound or CT guided biopsies or blind procedures. So, tumors often exhibit significant cellular and molecular heterogeneity with different areas showing varied genetic expression, genetic mutation, receptor expression, and metabolic activity. In some instances, tumor mass includes both the viable and non-viable or necrotic tissue. Conventional biopsies typically sample only a small portion of the tumor. Uh, Potentially, this leads to missing out of the lesions and therefore leading to false negative results. It has reduced sensitivity in small lesions or early stage lesions, especially those located in challenging or inaccessible areas. This leads to increased risk of sampling error. Longer time is another issue. In CT guided biopsy, due to multiple check CT and slowly advancing needle, it prolongs the time of the whole procedure. So to fill in the gaps of conventional methods, the advantages of functional imaging, like metabolic information, is combined with the advantages of anatomical imaging, that is to localize the lesion precisely. This hybrid approach of using two modalities which complement each other is fulfilled with PET-CT guided biopsy. So PET-CT guided biopsy aids in accurate targeting in heterogeneous lesions for better diagnostic yield. It has the longer retention of radiopharmaceuticals. Unlike contrast agents in CT, which washes out rapidly, radiopharmaceuticals exhibit prolonged retention, facilitating longer biopsy window and a delayed tissue sampling. PET-CT plays a crucial role in oncology by enhancing biopsy selection through the identification of multiple lesions and guiding therapy assessment by targeting the most metabolically active lesion. So, in this section, I will talk about robotic arm use in guiding PET-CT biopsy. Robotic biopsy system is a planning and targeting device which enables users to determine the path of biopsy. It operates in 5 degrees of freedom. This means the robotic arm can move in 5 ways to precisely position the needle. It can move forward and backward to insert or retract the needle, side to side to adjust position. It also rotates, tilts, and spins, allowing fine adjustment for accurate targeting. The system has sub-millimeter and sub-degree accuracy. In this image, we can see the robotic arm and it is attached to this monitor. The robotic system is docked along with the PET-CT machine, as we can see in this image. Now, let me take you through the procedure of PET-CT guided biopsy step by step. The first step begins with patient referral from various departments, usually for a suspected malignancy, although there could be other indications as well. The patient provides with consent and routine investigations like coagulation profile and viral markers. And then the patient undergoes a whole body PET-CT as routinely it is done. A prerequisite for biopsy is positive lesion on whole body PET. After confirming this, patient is asked to lie down on the table in the preferred biopsy position based upon the site from which the biopsy is to be taken. In this image, since the biopsy of prostate is planned, the patient it was planned through transgluteal route, so the patient was lying in prone position. The third step is the biopsy planning stage. The monitor, as seen in the video, it is used to set the critical parameters. First, the target point, that is the area of maximum uptake on the image, and the entry point, which is a point on the skin surface, is marked on the image. Then the needle length is fed into the system. The trajectory and angle are carefully confirmed on the image to ensure no critical structures are intersecting the needles. After the planning is done and all inputs and plans are finalized, the robot automatically determines the X and Y coordinates and the arm aligns itself to the defined trajectory for the needle insertion. In this image, we can see the robotic arm and the needle inserted over it. The skin surface is shown below. The site is prepared in an aseptic manner and infiltrated with local anesthesia. Then the coaxial needle is inserted. After placement of needle, next step is confirming the position of the needle. So a check CT is required to confirm the location of the needle. The spring-loaded biopsy gun is introduced through the coaxial needle and a minimum of 4 tissue cores are taken. These samples are taken from a single puncture. The tissue samples then are collected in a collecting vial and sent to pathology. After removing the needle, the site of needle entry is compressed manually and the patient observed for an hour before being discharged. So this video shows the steps of prostate biopsy using robotic arm. After positioning the patient stable and immobile, a PET-CT is acquired of the pelvis region. The images are transferred to the robot and displayed on the monitor. On the screen, we can see the biopsy planning stage. The yellow line shown indicates the path of the needle. The grid seen on the upper side of the robotic arm is it is the robotic arm. This is the robotic arm which is shown on the image. Now I'll be playing the video. So after the planning is done, the site is prepared in an aseptic manner. Then the coaxial needle is placed to mark the site of entry on the skin surface and the region is infiltrated with local anesthetic. Now the needle is being inserted. Once the needle has been inserted, the robotic arm is pulled back from its location. To confirm the correct placement, a check CT is required, which is reviewed. After that, the trocar stylet is withdrawn and the biopsy gun, it is inserted through the coaxial needle. Samples are taken and collected. So what are the advantages of using a robotic arm? It is a fast and accurate targeting method. It perfectly aligns with PET CT in real time. It gives assistance with angulation and depth control. It minimizes human errors and movement deviation. It reduces number of needle passes, risk of hemorrhage. So now I would like to call Dr. Siddharth, who will be sharing with you the experience in our department.
Good morning, everyone. I'll be briefing you about the experience of PET-guided robotic biopsy in our department. We have major experience in two areas of biopsies. One is FDG PET-guided intrathoracic biopsy, and the other is gallium PSMA PET-guided prostatic biopsy. First, I'll be talking about the intrathoracic biopsy. So the first case is of a 53-year-old man, a smoker, who complained of cough and breathlessness since 6 months. CT thorax revealed a near complete collapse of the right lung with high suspicion of malignancy. As you can see on the CT image, it is difficult to differentiate between the tumor and consolidation. So the patient underwent FDG PET CT for localization of the tumor. In the axial PET CT, we can see the FDG avid mass lesion, which is located centrally with area of consolidation noted both anteriorly and posteriorly. The biopsy needle was guided to the most metabolically active part of the tumor and the tissue sample was taken. The second case and the tissue sample came out to be positive for adenocarcinoma. The second case is of a 24-year-old female who is a treated case of medullary carcinoma thyroid. Her calcitonin level was 511 international units per ml. 18F FDG and 68 gallium Dotonox scan were done. FDG scan revealed a non-avid deposit in D6 paravertebral region, but Dotonox scan was avid. PET-guided biopsy was done, which confirmed metastasis from medullary carcinoma thyroid on histopathological examination. This case highlights the role of gallium Dotonox imaging for medullary carcinoma thyroid and rare site of metastasis, which was proven by PET biopsy. So a study was conducted in our department in conjunction with Department of Pulmonology and Radiology between a period of June 2014 and June 2015, which included 24 patients presenting with suspected malignant intrathoracic space-occupying lesions. So 24 patients underwent FDG PET-CT guided biopsy. The indications were a known or likely primary on PET-CT or suspicious lesions with FNAC CT guided biopsy, which turned out to be negative. So the results were that the procedural yield came out to be 100%, diagnostic yield was 96%, 2/3 of the patient turned out to be malignant, and 1/3 of the patients turned out to be benign. In the complications, only one patient suffered pneumothorax and hemothorax, which resolved spontaneously on subsequent follow-up. A study was done by Juliano and his colleagues to compare 18F FDG PET CT and CT performance in guiding percutaneous biopsies with histological confirmation of lung lesions. In 341 patients, of whom 216 underwent 18F FDG PET CT guided biopsy and 125 underwent CT guided biopsy. The conclusion was that PET CT guided biopsy of lung lesions led to fewer inconclusive biopsies than CT guided biopsies with almost similar complication rates. Now I'll be talking about prostatic biopsies. A 64-year-old male complained of frequency, urgency, and hesitancy of micturition for 8 months. The symptoms gradually worsened and new onset of lower back pain was found. Ultrasound abdomen done in June 2024 revealed prostatomegaly. The serum PSA of the patient was 39.65 nanogram per ml. The multiparametric MRI done in July 2024 showed a Pyrette 3 lesion in left peripheral zone of prostate. The patient had difficult approach due to the fact that patient had hemorrhoids, and since rectal bleeding is a common complication with transrectal ultrasound-guided biopsy, it was avoided. So the patient underwent gallium PSMA PET CT scan for staging and to subsequently start treatment. In the PET CT scan, we could see a prostatic mass with local infiltration and multiple skeletal metastases as evident in the MIP and the fused PET CT images. So the patient undertook 6 cycles of docetaxel. However, the disease progressed owing to the rising serum PSA levels. So for further management to start PARP inhibitors, prostatic biopsy was desired to check for mutation. The NCCT axial image revealed a mildly enlarged prostate. We can see the PSMA prostatic lesion, PSMA expressing prostatic lesion in the left peripheral zone in the axial PET CT image. The biopsy needle was positioned to target the area with the highest SUV. Finally, the tissue sampling was done after successful guidance of the biopsy needle to the target lesion. In this case, we can clearly see that transgluteal PET-guided biopsy could be done when the conventional biopsy could not be done due to a difficult approach, as explained before. So the fourth case is of a 67-year-old male who complained of avoiding lower urinary tract symptoms for 3 years. The serum PS of the patient was 4.1 nanogram per ml. Multiparametric MRI done in November 2024 showed a Pyrette 3 lesion in the left peripheral zone. Patient underwent a gallium PSMA PET CT in January 2024, which showed a PSMA expressing foci in the left posterolateral aspect and apex of prostate as pointed in the arrows. In the axial CT image, we can see mild prostatomegaly. Fused axial PET CT image reveals a metabolically active region in the left peripheral zone of prostate. Biopsy was taken from the region of the highest SUV. Histopathological examination turned out to be positive for adenocarcinoma, Gleason score 3+3. Through this case, we can see that prostate biopsy yielded positive results in patients even with relatively low serum PSA levels. A meta-analysis published in European Urology Oncology Journal 2022 showed that for even Pyrette 3 lesions, the sensitivity of PSMA PET-guided biopsy was 69% and specificity was 73%, suggesting that PSMA PET biopsy could be particularly useful in evaluating Pyrette 3 lesions also. So I'll be sharing an experience of prostatic biopsy from May 2021 to September 2024. During this time, 132 patients underwent 68 gallium PSMA PET CT. These patients were referred for biopsy and had a persistent serum PSA of more than 4 nanogram per ml and or a Pyrex of more than equal to 3 on multiparametric MRI. Out of 132 patients, 92 patients came out to be PSMA PET positive. The positivity criteria was a SUV of more than 8. The mean age of the patients was 64 plus minus 7 years. So 92 patients underwent PSMA PET guided biopsy. So the distribution of serum PSA values was that 42% of the patient had a serum PSA of less than 20 nanogram per ml. 25% of the patients had a serum PSA between 20 and 100 nanogram per ml, and 33% of the patients had a serum PSA of more than 100 nanogram per ml. Biopsy outcome and follow-up. 92 patients underwent PET biopsy. Adequate tissue samples were obtained for histopathological examination, except in 2 cases in which we had inadequate tissue sample. Out of the 92 patients who underwent PET-guided biopsy, 78 turned out to be positive for prostatic carcinoma on histopathological examination, and 12 turned out to be non-malignant. Out of the 78 patients, 59 patients had a serum had a Gleason score of more than equal to 7, and 19 patients had a low-grade Gleason score of less than equal to 6. Out of the 12 patients who turned out to be non-malignant in histopathological examination, all of them underwent transrectal ultrasound-guided biopsy, out of which only one patient turned out to be positive for a low-grade adenocarcinoma of Gleason score of less than equal to 6. But the rest 11 still remain negative. So the diagnostic yield in our study of PSMA PET-guided biopsy was 97.83%. The sensitivity was 98.7%. Specificity was 100%. Positive predictive value was 100%. And negative predictive value was 91.7%. In a prospective study done in PGI Chandigarh in 2022 of 78 participants who underwent gallium CX68 PSMA PET-CT guided robotic arm assisted transgluteal prostate biopsy, they had also similar results with similar diagnostic yield of 96% with similar complication rates. A meta-analysis was done recently, including 5 prospective studies with a total of 497 patients to evaluate the diagnostic accuracy of PSMA PET-targeted biopsy in detecting clinically significant prostate cancer. The pooled sensitivity of PSMA PET-CT biopsy was 90%, indicating a high ability to detect clinically significant prostate cancer, and specificity was 93%, which is in our conjunction with our study also. So PSMA PET-CT guided biopsy provides a one-stop solution for early diagnosis and staging of prostatic carcinoma. So the yield of TRUST-guided biopsy. This is a study regarding the detection rates of TRUST-guided biopsy conducted in a Southeast Asian population, which retrospectively examined 804 men who underwent transrectal ultrasound-guided 12-core prostatic biopsy from a period of January 2012 to April 2014. Prostate biopsies were performed on men presenting to a tertiary institution when their serum PSA levels were 4 nanogram per ml and or when they had suspicious findings on digital rectal examination. So as we can clearly see, the detection rate of TRUST biopsy on abnormal digital rectal examination was 59.2%. And for a serum PSA value of 0 to 4, it was 9.5%. For a serum PSA value of 4 to 10, it was 20.9%. Between 10 to 20, it was 38.4%. And for more than 20 serum PSA value, it was 72.3%. The overall detection rate of TRUST-guided biopsy was hence 35.1%, compared to our study, which had a PET-CT guided diagnostic accuracy of 97%. However, I would like to highlight the fact that the detection of TRUST-guided biopsy increased significantly with rising serum PSA levels, reaching up to 72.3% when the serum PSA was more than 20 nanogram per ml. So the complications which we faced in the prostatic biopsy was that 64.4% of the patients had intra-procedural pain. However, I would like to say the mean VAS score of the procedure was just 2, indicating minimal pain. As a result, all patients remained stable throughout the biopsy and subsequent scan with no significant movement. There was persistent pain at 48 hours in 26.6% patients. 3.3% of the patients faced hematuria, and 6.6% had gluteal hematoma. 5.5% patients faced lower urinary tract symptoms, and none of the patients had fever. This is in conjunction with the study in PGI Chandigarh, which had similar complication rates. So the complication rates of TRUST biopsy, a meta-analysis of 79 studies with thousands of patients was done to study the complication rates of TRUST-guided biopsy. It was found that 65% of the patients had hematuria, 6% patients had lower urinary tract symptoms, and 1% of the patient had sepsis. There were certain TRUST-specific complications, which was hematuria, which was seen in 93%, erectile difficulties, which was found in 34% of the patients, and rectal bleeding was found in 37.7% of the patients. If we compare it to the robotic biopsy, in our experience, hematuria was only faced in 3.3% of the patients compared to 65% patients in TRUST biopsy. The rates of lower urinary tract symptoms was similar. and none of our patients faced sepsis. However, in trust biopsy, we can see 1% of patients had sepsis. So based on our experience and comparative studies, we can conclude that robotic arm-assisted PET biopsy demonstrates a high diagnostic accuracy with lower complication rates comparable to major institutes across the country and the published data. A retrospective study conducted over 5 years at a center in North India assessed the effectiveness of 18F FDG PET CT guided metabolic biopsies in patients with suspected malignancies who had previously inconclusive anatomical biopsies. The study included 190 patients who underwent PET CT guided biopsy. Adequate tissue samples were obtained from all participants, with 85% confirmed as malignant, resulting in a diagnostic yield of 96.9%. The post-procedural complications occurred in only 13.1% patients. This shows that PET biopsy can not only be used just in intrathoracic and prostatic lesions, but also in lung, lymph node, liver, and bone malignancies with almost a similar diagnostic accuracy and fewer complications. So what are the possible applications? In oncology, in heterogeneous lesions, conventional biopsy may miss aggressive areas, whereas PET-guided biopsy targets the most metabolically active region, improving diagnostic accuracy. For non-enlarged lymph nodes, PET can detect metabolic activity even in normal-sized nodes, aiding in early disease detection. It is also valuable in distinguishing post-treatment changes from residual or recurrent disease, where anatomical imaging alone may be inconclusive. Additionally, PET helps differentiate inflammation from malignancy, minimizing false positive results and ensuring precise diagnosis. In case of infections and inflammatory diseases, PET helps localize active infection sites that are difficult to reach. It is particularly useful for detecting focal inflammatory lesions with no CT changes, where metabolic activity can reveal pathology even before structural alterations occur. For unclear masses or lesions with a necrotic component, PET helps differentiate viable disease from necrotic tissue. In cases of relapse or persistent disease, metabolic biopsy ensures accurate assessment and guides appropriate therapeutic decisions. So what are the future applications beyond diagnostics of this procedure? The list of tracer is endless. We have numerous radiopharmaceuticals that target various molecules. So we have FAPI-PET-CT for cancer-associated fibroblasts. We have 68 gallium dotatate for neuroendocrine tumors. We have 68 gallium PSMA for prostatic cancer, copper 64 ATSM for hypoxia imaging, and zirconium 89 trastuzumab for breast cancer. The list of tracers is endless, so I've mentioned just only a few tracers. Facet joints are a common source of chronic back pain due to degeneration, osteoarthritis. 18F sodium fluoride PET-CT detects increased osteoblastic activity in symptomatic facet joints, identifying the exact pain-generating regions for localized injection. We can also use it in radiofrequency ablation in cases of hepatocellular carcinoma, renal cell carcinoma, and osteoid osteoma. We can see the real-time ablation and reduce the risk of recurrence, which happens due to incomplete ablation. So as I've said before, the advantage of PET-CT guided biopsy is that it is a safe, accurate, and precise method. However, there are certain challenges that we have to face. First is the cost of the FDG PET-CT. Then we have the steep learning curve in mastering tough-to-reach locations such as retroperitoneal tumors. There is a radiation phobia among patients as well as physicians, although I would like to emphasize on the fact that the radiation absorbed dose is very much within the permissible limits recommended by the ICRP. The major challenge that we are facing is the slow awareness of physicians regarding metabolic biopsy, leading to its underutilization. However, I think this might change after this CGR. So the take-home message is that functional biopsies, like those guided by PET-CT, target areas with high metabolic activity, increasing the likelihood of detecting aggressive tumors even when standard methods are inconclusive. The precise targeting afforded by functional imaging helps reduce the number of cores needed, potentially minimizing complications and discomfort compared to standard biopsies. This information helps determine the most appropriate management strategy, whether it's active surveillance, surgery, radiation therapy, or other treatment modalities. I would like to thank the Department of Urology, Pathology, and Pulmonology for their assistance. I would like to thank you all for your patient listening, and I would like to conclude by saying that change is the law of life, and those who look only to the past are certain to miss the future. Thank you.
After you can come and join here. So let's have the questions. Yes, Rakesh.
Thank you for an excellent presentation. So I have my primary question. There are two things in this procedure. One is metabolic guidance. The other is a robotic arm. And I think we need to separate the two. A whole lot of what you showed was due to the use of robotic arm. It reminds me of my grandmother who thought before exams it was important to read, but also to eat 10 almonds every morning. She always thought my results were because of the almonds, and I thought that they were because of my studying. Which one of the two matters? A lot of it is the use of robotic arm, and I think the robotic arm would be much better if we use it with the CT rather than with PET CT. Second, I think we physicians need to be careful saying that we have radiation phobia. I think we have radiation philia. One can see in the ward patients having CT every alternate day, almost like the temperature and pulse measurement. Coming to your data, I don't think on those data you can calculate positive predictive value, negative predictive value, sensitivity, and specificity. If you want to show that it works, you need to take patients and randomize them to conventional biopsy and metabolic, whatever you want to call it, biopsy, and show that it performs better, and ideally that it changes the prognosis. In CA prostate, what does biopsy diagnosis really change? It's itself, to the best of my understanding, an area where there is a lot of confusion. I'll stop here. Thank you.
Okay, thank you, sir, for the question. So first, I would like to come to your point of data. So yes, I agree. We need head-to-head comparison for sensitivity and specificity. But for our limited data, we actually take gold standard as a histopathology and our SUV max, that PSMA uptake, as a variable. So by this way, we came to sensitivity and specific data, but I agree with your point.
But whatever you do first will appear to have a good sensitivity. If you had first done truss, 85–90% will be positive. In the remaining, when you go ahead and do metabolic, you will find very few positives. This is a problem of the data set. When large proportion are positive, whatever you do first will appear to do very well.
Yeah, I agree with this point because we actually excluded the patient who was PSMA negative. Well, we did the scan. So we take only the PSMA positive patient. Then whether this technique is based on metabolism of the tumor or it is based on the robotic or CT feature. So I would like to tell we harness the potential of hybrid imaging. So for the anatomy, we rely on the CT images, and within this anatomy, within this tissue, which part of the tissue is most radioactive, most metabolic, we decide with the functional imaging. And what is the role of robot here? Robot actually gives us more precision and it reduces the human error. Like I saw you in the second example. Even the smallest degree of movement.
Definitely understand what each does. The question is, if there is any gain, I'm not saying that there is any gain by doing this. If we accept that there is a gain, is the gain because of robotic arm or is the gain because of metabolic guidance? Can we distinguish between the two?
Yes, so the overall literature which is using the PET-CT guided biopsy, this robotic arm biopsy study is only concentrated in the India because this is a new thing and this is make India thing. But the all over literature in the world that is saying the these are doing the metabolic biopsy without using robotic arm. And yes, literature says there is advantage of doing metabolic biopsy even when metabolic this robotic arm is not there.
So, Dr. Aftab, yeah, go
Yes.
ahead. Yeah. So regarding if you go through the literature, you can find actually PSMA target biopsy compared with the conventional MRI target biopsy. So they are not better actually. They may be equal or lesser than that. But when you combine both the approaches, then it's become the more sensitive and specific as compared to the either approach. And second, regarding the cognitive this thing, fusion biopsies or cognitive biopsy. So if you go to the literature, whether you go for the cognitive biopsy or whether you go for the fusion, the results are the same actually in MRI targeted biopsy actually if you see. So do you have any kind of PSF pad where you can fuse with the PSF pad? So then you can take the 12 core biopsy. Otherwise, translutal biopsy, I don't think you can have a systemic biopsy approach. You can take 1 or 2 core, 3 core maximum there. So that is the problem with the translutal.
Yes, I agree with your point, Dr. Uday. But then again, what I said, this is a hybrid imaging. Yes, I would be very happy if we can fuse these truss images, these PET images with the truss guidance. So if there is a software available with us where you are doing transrectal ultrasound and we give you the images, fuse the images with the real time. So I will be happy with this thing. And yes, this is unmet need in the urology and the nuclear medicine thing. I hope this will be solved.
Yes, one more regarding the comment. If you see the major advantage of getting the functional imaging like PSM pad, if the prior biopsy is negative, so sometimes we find the patient who we got the biopsy done and the biopsy comes negative and still there is a rising PSA or something, suspicion of having cancer. Then we get the PSM pad done and if you can find the lesion, then we can target. So that in that situation, you require only 1 or 2 biopsy code. That is fine. And one area is that if there is a, you got the MRI done because in every patient we get the MRI prostate done before going for the biopsy. So if you find the pyrite 3 lesion, actually, so that lesion actually is borderline. Some patient may have a prostate cancer, like around 20% patient may have a negative biopsy. So then there is a role of PSF pad and then you can target the lesion if you find that. Otherwise, you can avoid the biopsy pyrite 3 lesion.
So regarding trust guided negative and PSMA guided positive results. So in our experience, we have around 15 patients who underwent trust guided biopsy and they were negative. Out of these 15 patients, 3 came to the positive in the PSMA guided biopsy. So it comes around, I say 20% something.
Yeah. And one more question is regarding you got a lot of very high sensitivity and specificity. Because of that, if you go through your data, then most of the patients were the high group patient. And more than 100 PSA, more than a very high risk group actually, if you see. So even if you do just a finger guided biopsy, you will find the positive. Okay?
Yes, I agree with the data bias. We have taken cutoff of SUV 8. So if you decrease this SUV, definitely we will increase the sensitivity. But then again, at the sacrifice of, we sacrifice our specificity. Yes, we had a data bias.
Total overall, more than 90% were positive. In this group, is a biopsy even needed is the question that I would raise. So by this, these data don't prove anything when you have 90% people are positive.
So, yes, sir, your question is actually the next level, what the urology is now doing. The new trial are going on where when there is SU max of more than 8, in the PSMA PET CT, they straight away going for the management like prostatectomy or diet without doing the histopathology. Sir, you are actually right.
So after regarding this thing,
Just 1 second.
Okay.
Let's let Anjali come.
So I think what we are discussing is ki what I get over and above the routine CT biopsy while this thing asking for any PET guided biopsy. So the only this thing situation which I can think of in my this thing specialty, sometimes like there is metastasis and inflammatory lesions where CT cannot distinguish. In majority of time it could. So maybe there is a role. The second thing is that we need. I'm talking not all would be taking up cases. So there is very limited role, I would say, and we need to specify. It is not like this thing, we could replace CT guided biopsy with PET guided biopsy. So, but the way it is being brought out is like it should be the enhancement, which it is not.
Okay, Neha.
Congratulations, sir. It was a very comprehensive one. And I like the take-home message, accurate tissue and accurate diagnosis. My question is, these biopsies are from the prostate and the intrathoracic lesions. So are we performing the biopsies from the different organ like intra-abdominal masses and deep lymph nodes? And second is we have shown the 5-year experience of PET guided biopsies from the intrathoracic masses. So do we have any comparative study? Because this is just a retrospective study. Do we have any comparative study with the CT guided biopsies? Because we have the good diagnostic lead in CT biopsies as well. Thank you.
So we can do biopsy from any organ. The only thing we are not getting adequate referral from the other clinician. And the second thing, head-to-head comparison with the CT guided biopsy. We do not have the head-to-head comparison study in our institute. In the endothoracic biopsy, there was around 15-20% who were CT guided negative, then sent for the PET CT guided biopsy.
I
think this data
getting
is
referrals from others is because they are getting adequate yield from the CT guided biopsy. So they don't need to get this expensive PET CT and a PET CT based robotic biopsies. Only when you are, as everybody is saying, that once those are negative and you have a high index of suspicion of malignancy and the lesion is small, heterogeneous, that is the time when people will send for these PET CTs. Okay, Rajneesh.
Congratulations. It's an excellent talk, actually. Scientifically, it's cutting edge. To the questions posed by Uday and maybe by Dr. Anjali as well, I think it's unfair to the technology itself, the questions that is, because the yield of a technology, and I think that's where your data failed, was to give us the added value over and above what is existing. And most of the questions are pertaining to that. From the perspective of the GIs, this thing, I think the yield would increase, would be really useful where you have difficult scenarios, like Uday pointed out, pyrite 3, or Anjali pointed out, you have a borderline lesion. From my perspective, a difficult area where you cannot have a second shot, or you don't want to have a second shot. So retroperitoneum, for example, masses close to vascular organs, where even though I know the IR people do an excellent job of targeting those CT guidance, but there's where you don't want a negative biopsy or an inconclusive biopsy. So you want a single shot. You know,
Yes.
So really you should concentrate, to my mind, on the incremental value of your intervention or investigation rather than on the baseline where, as Dr. Rakesh pointed out, you're failing because you don't have a denominator. You have a very, very focused denominator where you are thinking that's very good.
Agree, sir.
Have you analyzed your data with multiple core biopsies, single core versus multiple core with robotic arm? Do you single core biopsy or take multiple cores?
Okay,
Multiple cores. Yeah.
we take multiple, say 4 core, but these 4 are from the same area.
Same area.
Same area, same site. So actually, this is 1 core or 4 core. It doesn't matter actually.
Okay.
It matters that's why you take 4. Otherwise, you would take 1.
Yeah, it's because there is fear of missing something out, so we take 4 biopsy from the same area.
So have you analyzed data with multiple core versus 2 core or single core? Because diagnostically is better in multiple core like that.
Obviously, multi-core will always be better when we compare with the single core.
So questions from
That
students?
would be very simple, actually. You just have to label the 4 cores separately and give it to the pathologist. Tell them what is the yield on the first core, on the first 2 cores, first 3 cores. That question is very easy to
Yes,
answer.
we can do that. Yeah, thank you, sir.
So if you are targeting the any lesion actually, so you have to take 3, 4 or 5 core actually. For any, if you are targeting the lesion. Otherwise, in systemic biopsy, you have to take the 12 core.
Yes.
Okay, that is.
Now, students, let's hear from students. I hope there are some students, at least I can see few of them.
Students are there, ma'am.
Yes.
Ma'am, firstly, like guided biopsy or ultrasound guided biopsy, we get an early time and it is less costly. However, the PET guided biopsy, we have to ponder a lot, we have to think over it, and the date, that is the issue.
Okay, so tell us the logistics. As a resident's perspective.
Yes, caste is an issue with the PET guided biopsy.
Then early appointment, sir.
Okay.
We require early appointment for the patient.
This will be eternal question in the field of nuclear medicine, early appointment of FDG PET CT. I will say we need more PET CT machine in our institute. But even if you have 2-3 scan, the population is so huge, we will again have a waiting list of 2-3 months. But for you, for our resident, I say, just admit the patient and comes to us. You need this patient PET CT in early date. We will do within a week. Yes.
I would say the opposite, that if we start using tests rationally, you will reduce your time, because you saw here, most of these could have been done biopsy by the usual way, because their PSA was anyway more than 40. They had whatever he said, SUV max of 8 or whatever, I don't remember the figures. I mean, they would have been treated even without doing those biopsies. So if you save those times, then patients who really need it will get an early date. Yes, rational use of any test, be it in our lab, be it in their radiology, anywhere. Most important problem with the residents and also the faculty is indiscriminate use of tests. Yes, Jayanti.
Similarly, which I don't know how we can make it.
Okay, we have another person at the back. Yes.
Another problem as a pathologist we face in the lab is we get the tissue when the only infarcted or necrotic area is there in the tissue. So another value which you can add is getting the viable tissue, a viable tumor from the tissue.
If that we are doing.
Yes, Rakesh.
Would it be better to have a robotic arm in radiology so that they can do it into the CT guidance?
Yes, we will have the last word. So any radiologist around, how much of robotics are the radiologists using? Because if it is an India made, I have done that thing, that is an India made thing, it can be aligned to a CT scan also. It is aligned. It is aligned. Okay.
Ultimately, they said they validate with the CT and then ultimate guidance is the CT, not by.
Okay. So do we have any more questions from anybody else? Okay, Dr. Sinha can have.
Yeah,
Dr. Gambhir.
actually, I'm just a layman in this area. But I get an image about, get an impression about the hybrid imaging which you mentioned. I get the impression that probably you would recommend hybrid imaging for every patient.
It's not like that. There is appropriate use criteria in the nuclear medicine for every investigation. And as the ma'am said, judicial use of investigation is the key.
Yeah. So lot of good questions. You see this, though the machine is Indian, so it's being sort of on a course of validation. So a lot of good points like Rakesh said, to compare to really need to randomize. So the prostate group is, the trusts were done only when the vice versa. Normally trust is done, but in this case, in these 80-90 patients, we did this our PET CT and then trust if negative. So these studies, the way people and literature and thought process is coming is sort of a validation how to use this precise method of getting the right tissue. So if we very acutely make the guideline, okay, as per the size of lesion or the biomarker in PSA case, if this is more than this as it is, you are going to get a from the other method, MR guided or whatever ultrasound guided biopsies or the trust guided. So those precision definitions and criteria are evolving. They are not yet there. So the questions are valid. So the first part of this slow progress as why to refer, we are not asking for refer. We are in a way validating this new technology as other centers are doing. So the validation requires that it is safe, it is fast, it gives radiation less than that. And then you go on to the core thought processes, how to screen, how to make it cost effective. Do we need to do it all patient or do we need to do it patient where CT is failed? So all the thoracic cases were failed CT cases, multiple failures, T3 biopsies on CT failing. So our thoracic lesion were all failed CTs, and there we did this and got this very high yield of it. And in prostate was the set of group which were per se beforehand. Of course, it take time if we say we put cutoff value of PSA that this is difficult area for other biopsy, trust biopsy. So only those groups, that number will build up slowly. So this is to establish the kind of, doability, performance of this technique. So we need to fine tune it further.
Okay, thank you, Department of Nuclear Medicine, for your presentation. And next week we have